First of all, I would want to introduce the chair of the third session, Dr. Tergas, and also Dr. Gordon and Dr. Lepsik, who will be presenting. Just briefly, I would want to provide the bio of Dr. Tergas. Dr. Tergas is assistant professor here at City of Hope, and she's an MD, MPH in the Department of Surgery, Division of Gynecologic Oncology at the Department of Population Science, Division of Health Equity at City of Hope Comprehensive Cancer Center here in Duarte. She is an affiliate member of the Weill Cornell Medicine Center for Research on End of Life. She attended medical school at the University of Miami Miller School of Medicine. She completed a residency in OBGYN at the University of Chicago and a Gynecologic Oncology Fellowship and Master's degree in Public Health at Johns Hopkins. She's an NIH-funded physician scientist and an NIH Health Disparities Research Institute scholar whose research focuses on health inequities among marginalized groups, particularly in the end-of-life care, delivery, and HPV cervical cancer screening prevention. She currently serves as the editorial board of the Journal of Gynecologic Oncology. Welcome, Dr. Tergas.
Thank you so much, Dr. Gambo, for that kind introduction. And I have the pleasure of introducing our next speakers, Dr. Lepsik and Dr. Patricia Gordon and Ms. Lepsik, and they are going to present jointly on community-based HPV testing and treatment in Kenya. Dr. Patricia Gordon is a founding director of CureCervicalCancer and chair of the board. She received her MD degree from University of U.S.A. and was also the radiation oncology chief resident there. She has been practicing medicine for over 25 years, was a partner at Beverly Hills Radiation Oncology, and served on the medical team at the Beverly Hills Cancer Center. Her commitment to saving women's lives in the developing world has brought her to an additional career as a nonprofit leader and international women's health advocate. In 2021, she was nominated as a top 10 CNN Hero of the Year for her efforts to fight the global epidemic of cervical cancer. Using the See and Treat method, she founded CureCervicalCancer, which trains local healthcare professionals to screen and treat women for cervical precancer. The organization has established 106 sustainable and ongoing CureCervicalCancer clinics in Kenya, Tanzania, Ethiopia, Nigeria, Haiti, Guatemala, Vietnam, and training programs in rural China, where help is needed the most. Dr. Gordon is committed to leading CureCervicalCancer into the future and has dedicated her life to overcoming this tragic and needless epidemic. Joining Dr. Gordon today as co-presenter is Ms. Rebecca Lepsik, Executive Director of CureCervicalCancer Organization. Ms. Lepsik is the Executive Director of CureCervicalCancer Organization. She is a registered nurse specializing in women's health. She brings over 10 years of combined clinical and professional experience working in the healthcare and humanitarian sectors. She has built effective international programs and led global teams to conceptualize, implement, and scale programs that reached over 250,000 women with screening, treatment, and education. She designed a specialized training curriculum that reached more than 1,500 healthcare workers and community health volunteers and built partnerships with national ministries of health, local governments, NGOs, and key stakeholders, resulting in the expansion of the CureCervicalCancer program, again, in more than 106 healthcare facilities across 10 countries. She has also spent several years as a case manager for persons living without a home, survivors of domestic violence, immigrants, and refugees. She holds a Bachelor of Arts in Psychology and a Bachelor of Science in Nursing. Her passion is to increase access to quality healthcare for underserved women globally. And I'm very looking forward to both of their presentations today. Thank you very much.
Well, thank you everyone for coming. It's a pleasure to be here today. This is almost the antithesis of this morning. We are going to, there's no molecular slides. There's no studies. There's just a lot of getting your hands dirty and work. So about 16 years ago, after a successful career as a radiation oncologist in Beverly Hills, I decided I wanted to do something on a global arena. And I learned 16 years ago that 350,000 women die every year needlessly. They die of cervical cancer, which is a totally presentable disease. It's 100% preventable. You all know it's caused by the HPV virus. So I took a trip to Dakar, Senegal, where I was with a group of radiation oncologists in an attempt to put in a very fancy $10 million linear accelerator in the nation's capital, to find that the machine never even arrived. But there I was with a bunch of hardworking radiation oncologists and a bunch of vaginal speculum that I brought along in my suitcases. And we went out to Mabor, which is a French village, and we started to screen women for cervical cancer, which is the leading cause of death for women in Senegal. And sure enough, we had discovered about 10, 15 women in the morning that had these dense, white, opaque lesions on their cervix. And I didn't have a cryotherapy gun. So I went searching around the area of Mabor. 3.5 hours it took me to find a cryotherapy gun, which was an interesting thing. I'm a Jewish woman in a Muslim country looking around for a cryotherapy gun, but I found one. And I came back, and there was another 10 women waiting in line to be screened. And that day, I believe we actually, not screened, treated. So I believe that day alone, we treated about 35 women with opaque, dense, white pre-cervical lesions on their cervix, cervical precancer. And that week, for the rest of the week, my group of well-intentioned radiation oncologists without a linear accelerator joined me to screen and treat women, because now I had borrowed a cryotherapy gun and a 25-kilogram non-siphon CO2 tank, and we were up and running. And by the end of the week, we had screened 900 women and treated about 60 women. And I came home and I told my husband and that this was one of the most incredible weeks of my life, and that maybe I was going to quit my practice in Beverly Hills and devote my life to screening and treating women around the world who need it most. And he said, well, why don't you go on one more trip and see if you still like it? So I found myself in the northern region of Ethiopia in the Tigray area. And I trained Sarah and Sahai, and this time I came with cryotherapy guns. I know I wasn't looking around for them. I came with cryotherapy guns. I came with other doctors, other gynecologists. I'm not a gynecologist, and a lecture. And we lectured to about 20 nurses, and 2 of those nurses, Sarah and Sahai, they were really adept at screening women and recognizing these dense, white, opaque lesions, which are pre-cervical cancer lesions. And on Thursday of that week, I was standing above watching them screen the women. And I went, how do I take my cryotherapy guns back with me? That really wouldn't be very nice. I think I better think about leaving those cryotherapy guns with Sarah and Sahai. And I talked to the head of the hospital, Dr. Emmanuel Hale, and I said, well, if I left my cryotherapy guns, do you think you could report back to me every month on the number of women screened and treated? And he said, sure. And now 13, 14 years later, Sarah and Sahai still report back to us on the number of women screened and treated, thus establishing the first CureCervicalCancer screening and treatment program in the world, CureCervicalCancer's first program. We've since been back, Rebecca and I, many times. We've upgraded their cryotherapy gun to a thermocoagulator gun, and they're just doing fine. And so we're going to get to this very fancy HPV clinic, the very first mobile HPV clinic in the world, shortly, but I thought it was worth an explanation of how we got there. I shortly thereafter that trip of going to the northern region of Ethiopia started a 501c3 dedicated to the secondary prevention of cervical cancer in low and middle income countries. We will go through what this HPV screening and treatment program actually looks like. It's not the See and Treat program that's everywhere in the world. It's the first mobile HPV screening and treatment program in the world and how it came about. I as opposed to you guys, I thank my team at the beginning. So this is our team. We have a Los Angeles-based team. None of this could be done without Rebecca Lepsik. And we have also in Los Angeles, McKenna and Julianne. And then we have a full-time paid team in Kenya. It's in Western Kenya, in and around Kisumu was their base. And they are Samson, Dorcas, Adriano, Peter, and Millicent. Millicent is just hired to take patients who have advanced disease that isn't treatable with thermocoagulation alone and get her to the next higher level of screening. So this is CureCervicalCancer and our global impact around the world. Thus far, we've screened 188,000 women, but that's not really true because most of our clinic, that's just the number of women we can document. Most of our clinics, well over 50% of them, have been turned over to the ministries of health. So we no longer receive data from those ministries of health. So that number I estimate is at least 50% low. We've treated almost 13,000 women, trained 766 healthcare professionals, nurses, trained 1,700 community health workers. We have 106 sustainable clinics all over the world in 10 countries. But we're here to talk to you today about our mobile HPV clinic, the first of its kind. But that's where we are. And that's what I've done for the last 16 years and what Rebecca's done for the last 7, 8 years. And we're proud of it. Go ahead.
Gordon and yes. And thank you, Dr. Gumbo and the Global Oncology Group for having us here today. So we focused for the first 10 years of our organization on screening with BIA and treatment with cryotherapy and then thermal ablation. And we had some time, like everyone else, during the year of 2020 to reevaluate how we wanted to make an impact around the world. And what that resulted in, we wanted to bring HPV testing into our programs. And the WHO came out with a call to action and some guidelines, which I'm sure you're all very familiar with, around the same time. And I've circled here the 70% of women target to be screened with a high performance test, which would be HPV testing. And to make sure that those women who are high risk for cancer receive treatment or who have invasive disease. So that's what we set out to do. And 2 years ago, almost to date, we started a brand new program in Kenya, which we call Mobile Health for Mamas. We were very specific about the name and the name of the program in the community, because often cancer is affiliated with a death sentence and there's a lot of stigma surrounding this, and we didn't want that. So we're targeting healthy women. This is a partnership with a Kenyan organization called LVCT Health, and they focus specifically on key population, which is women living with HIV. Bristol Myers Squibb Foundation is one of our primary donors for this program, and they've just given us a grant to expand our program into new regions of Kenya, which we're very excited about and hope to bring City of Hope along with us into this expansion. And you see here also the Kisumu County government, because we partner very closely with local and national government. That's how we sustain our programs and how we grow. And what you're seeing in this picture is the very first mobile laboratory. That's a rented minibus. It's really made for tourism. And we outfitted the inside to be a mobile laboratory that's functioning on solar power. So I will tell you that it doesn't take very much to just get started. And we've had a tremendous impact in the last 2 years, which I want to tell you about. Our objective was to demonstrate a model. We are a small NGO. You might have figured that out by now. Our operating budget is about $1 million. And what we wanted to show is a model that's effective and scalable, that could be replicated by other NGOs, that could be adopted by governments in low resource contexts, to focus on secondary prevention with testing, with HPV testing, treatment for women who have high risk HPV, and linkages to advanced care. So in our definition of advanced care, we're including those women who need LEAP procedures, because in Kenya, that should be done at a facility, as well as those women who are suspicious for invasive disease. So we focused on Kenya because there's a significant need, and cervical cancer is one of the leading causes of death for women in Kenya. There's also a significant need for access to preventative care, both the vaccine, early detection, and treatment. And we chose Kisumu as our focal region for this pilot when we started, because of the high prevalence of women living with HIV in Kisumu. So you can see it's at 17.4%, placing these women at significantly higher risk for developing cervical cancer. And in Kisumu overall, there's about 120,000 women who are between the ages of 30 to 49. Of course, this 120,000 is from year 2022, so maybe more or less 120 by now. We started our community-based program to overcome some of these barriers that all of you are so familiar with in low and middle income countries and low resource context. And we recognized that it wasn't enough to increase access by setting up, centers for women or opportunities for women to get screened and treated. We also are trying to change health behavior. And to change health behavior, we have to invest heavily in education. So these are some of the barriers that our program set out to overcome. Oops. We focused on women who are between the ages of 30 to 49. And we adopted WHO's screen and treat approach, meaning that we decided that the benefits outweighed the risks of treating all women who tested positive for high-risk HPV. So I'll talk about that on a later slide. But in our program where we're going out to very rural, remote communities, this was the algorithm, the treatment algorithm that we decided to take. And this is also supported by Kenya's national cervical cancer strategy. We are using Attila Biosystems PCR testing system. We selected this testing system because it's durable, portable. Not too many PCR testing systems are running on solar power in a rented minibus. So this was the good fit for us. And we're currently using Attila Biosystems assay, which is grouping the high-risk genotypes of HPV according to their risk stratification. I'm so sorry, I keep pressing the wrong button. So I want to take you through in a series of pictures, because I think it's more interesting than looking at this chart, a breakdown of how our program actually works. But before I do that, I want to point out that again, we work very closely with the local government. So in Kisumu, we've worked in partnership with all of their team members from the health department team. And one of the benefits that we've had in Kisumu is that we have been able to map the women who are 30 to 49 according to where their house is and which caseload of community health volunteer they fall on. So in Kenya, they have a cadre of health workers who are not I would not say that they're formally educated, and their job is to provide health education to the community, and each of them is linked to individual households. So we have worked very, very closely with these community health volunteers. So we begin our project simply by mapping the households. Where do these women live? Which community health volunteers are they connected to? Also, which healthcare facilities can we partner with in this region of Kisumu? Because ultimately the healthcare facilities are going to be the custodians of care for the women that we're reaching. So the next step for us is to train, and we believe in training to build capacity in the local healthcare system. We've trained just for the Mobile Health for Mamas program. So just in the last 2 years, we've trained over 100 healthcare providers. And our training program is set up to be like a mentorship program. So it's not just a 1-week training. We're following these healthcare providers through a series of months to make sure that they have the competence and confidence to screen and treat women. We've trained over 1,500 community health workers and 7 lab technologists. And next, we conduct community education. So when we go into Kisumu, we have a targeted strategy. We focus on specific regions, and we target all of the eligible women within that region. So when we do the community education campaign, we send the community health workers door to door. They go with a video that's in a local language demonstrating how to do a self-sample HPV test. We also work very closely with the public health officers from the local government to go out and do public announcements, radio adverts. And I also want to mention that we work closely with influential community leaders, and especially with men in the community, as they're often the ones making the decision of whether or not their women can get screened. So this is one of our trained community health workers, and you might be able to see that she's holding the swab to take a self-sample HPV test. Another benefit of the assay used with Attila Amphire is that it's just a dry swab. There's no medium in the tube. So we're able to keep this, for about a week before it has to be brought back and processed. This is the inside of our new mobile laboratory. So the results are brought back, processed. With the Attila PCR testing system, we can get results in about an hour and a half. And currently, with 2 lab technologists and 2 testing systems, we have a throughput of about 700 samples a day. Women who test HPV positive are now invited to come to receive treatment. And what we wanted to do, again, community-based, was overcome that barrier of distance to a healthcare facility, as well as showing up to a healthcare facility that doesn't have the tools or the training capacity to actually treat women. So what you're seeing here is an example of one of our mobile treatment clinics. And women who come from their community, maybe this would be a 20 to 30 minute walk for them. They'll spend about 20 to 30 minutes here because we've scheduled them to come, and we have a team of providers who can give the treatment. Okay, I hope I can. There we go.
Every single thing you see in this picture, except that bus tucked away in the back, was brought through customs in Nairobi by our team. Every single thing you see here. We get to a critical mass of about 90 samples in the morning. These samples are run over to the minibus in the back. Well, no longer do we have that minibus. We have a very fancy Hino truck with a mobile laboratory, and the HPV tests are run. They're run 90 in the morning. Takes about an hour and a half. We entertain the women, we educate the women, we educate their husbands, and the women who test positive are invited to stay and get their treatment right then and there. And we do this in the morning, and we do this in the afternoon. This is called the one-step model. The model that Rebecca was talking about earlier with community health workers is a 2-step model where we go and collect thousands of samples and bring them back to the mobile laboratory and then go back out to treat them. can you just imagine? We're in the middle of absolutely nowhere doing this. So sometimes people think, well, can't you do a pap smear? And I go, well, no, there's no way to do a pap smear. And besides, HPV testing is the gold standard. And so this is what it looks like typically. And it's just, that's where we go, and that's what we do.
Dr. Martin. I do have a few more slides to get through, so I'm going to go through quickly because I want to share some of our results. But this is just a peek inside one of the treatment tents, one of our trained providers. So again, we are screening for eligibility for thermal ablation treatment using VIA and ruling out those women who are not eligible, who would then be referred for treatment, usually with LEAP procedure or have a biopsy. We have noticed over the years when we've been working in cervical cancer prevention and in this program, one of the gaps that we wanted to address was the linkage to advanced care. So what happens to these women who are HPV positive, but who are ineligible for treatment with thermal ablation? And oftentimes what happens to them is that they just get lost in the cracks. And we all know that. And I know that's something that Dr. Agembo and Mayu are particularly passionate about. So what we have done in this program is we have a client navigator, that's Millicent in the bottom right picture here. And she offers her support to any woman who is referred to the healthcare facility, either for LEAP procedure, which is the majority of cases, or for those women who are suspicious for cancer, deemed suspicious for cancer by our team and probably do end up having invasive disease. So having someone who calls you on the phone, who supports you face-to-face and often attends some of the primary referral appointments with the clients has made a world of difference. We also support in other financial aspects for the women who are referred, including providing their transport, which might be a couple of dollars to get from their village to the main referral hospital, providing the cost of first-line treatment. So, for example, women who have been diagnosed with invasive disease are going to need a number of labs and x-rays and things completed. And we help pay for some of those treatments so that they're to expedite the process, basically. And finally, very importantly, in Kenya, they have a national health insurance fund. It's about $60 annually to pay for one woman's care. And the National Health Insurance Fund will pay about 70% of advanced treatment. So about 70% of payments for chemotherapy and radiation. And this is really the difference between life and death for a lot of women. So for those women who qualify, we pay their premium. So in numbers and sheer numbers, this is the impact that we've had over the last 2 years. We've reached almost 20,000 women with free HPV testing, treated almost 4,000 women, and I'll talk about that number in a moment. And we've had 146 women that were successfully referred for higher care. So some of the indicators that we looked at were the testing uptake, treatment uptake, specifically for thermal ablation, successful client navigation, which we defined as a woman who attended her primary referral appointment, and also looking at the yield of each of our community health volunteers. So when we sent them out to the doorsteps of 30 households with 30 test kits, how many test kits did they actually bring back? And we also looked at the sample integrity, because very important to the success of this program is if we have community health volunteers who are really uneducated workers going out, bringing a self-sample test, a woman is collecting it, you know, if it comes back, is this an appropriate sample or enough sample that we can get a result from? So in essence, can the program actually work? I mentioned that we are very targeted in our approach. So we pick specific regions and we basically do a mass campaign where we're targeting all of the eligible women within that region in a very short period of time. And we've found that this has been really one of the keys to our success because it builds momentum and it builds a sense of urgency for women to participate. And we often find that women are very convinced to come and to do the screening or treatment because their neighbors have done it and they talk about it. So it creates a momentum that is to our advantage. So this is just showing you in Kisumu County particularly, there's 7 sub-counties. Again, thinking about 120,000 women spread throughout these sub-counties. Even within those sub-counties, we chose very specific wards. The sub-counties are broken down into wards, and those were the wards that we targeted, rather than going in and saying, we're gonna reach out to all the 120,000 women in Kisumu County, which I think we could have done if we also weren't restricted by funds. So I'll take you through some of our results quickly because I know we're at time and I want to leave time for questions. So first of all, looking at the testing uptake, most of the tests that we have done have been at the doorstep. We do have what we call the single visit model that Dr. Gordon was describing. But in terms of scalability, what we learned really quickly is that we can reach thousands of women. Even in our tiny program, we're reaching over 500 women a day by going to the doorstep with the HPV test. And of those women who we offered testing, over 27,600, 72% agreed to take the test. And I think that this is really evidence that, number one, there's a demand from women. Women do prefer to be able to take the test in the comfort of their own homes and to have the power over their own bodies rather than having a speculum exam. And also that the community health volunteers are more than capable of, to me, they're like the salespeople. They go on the door and say, hey, do you want to take this test? It could be life-saving, and convincing women to do screening. So now looking more closely at the yield for each of the community health volunteers, it was over 75%. So on average, the test kits given to each community health volunteer are about 30, and they would bring back about 22.5 test kits. So again, just a testament to the fact that they're very motivated and capable of being frontline workers for cervical cancer prevention. We looked at sample integrity that I mentioned before, and we have had 93% samples that are valid. Basically, we had to exclude some samples because of administrative errors, maybe a misspelling of someone's name, et cetera, and some samples because there simply wasn't enough sample or it was taken from the wrong part of someone's body, which, shows us that maybe the training wasn't done appropriately or the education. But we're very proud of, this is a testament to the training that we've done with the community health volunteers, showing them how to educate someone how to take their own sample. We've had a fairly high positivity rate in Kisumu County, and this might be attributed to the high prevalence of HIV. But about 30.8% of women tested HPV positive. And I apologize if this isn't the best graph to explain, but the majority of our women tested in the high risk category or high risk other category. And then you can see we had some women that had tested 1618 or 161845 also tested positive for additional genotypes. As far as the outcomes for women who were HPV positive, all of these women were invited to come to our mobile clinics for treatment. And we had about 69% of those women who were, we call them managed by our care team. So essentially, the majority of those women did come to the mobile clinics. Some of them did not come to our mobile clinics, but we have documented that they went to their local healthcare facility where we also trained the providers. There were still a significant portion of women who were lost to follow-up, meaning that they either refused to come for treatment or that we weren't able to contact them. They weren't responsive to coming to the mobile clinics afterwards. So this is an area that we are continually working to improve, and it's a big challenge for us. And then looking finally at the referral outcomes, over 49% of the women that we referred attended their primary referral appointment. And I do want to point out that, you know, out of almost 20,000 women screened, we had 146 referrals. And it's a tiny number, but these are the women who really need our help. So when we think about resources to give these women transport or paying for their national health insurance or making sure that they have a client navigator to help guide them through the higher level of care, it's really just such a small bucket of women. Most of the women that were referred of this 146, of that 2.5% were suspicious for cancer and 1.2% for large lesions. So those would be women referred for LEAP. Again, we know that we need to do better here because we're losing still a lot of women to, you know, who aren't compliant with their follow-up treatment. Okay. So I think I've talked about that. So, you know, just a few of our keys to our success. I've already talked about how closely we work with the local healthcare department, the county system, and that we're very targeted in our campaigns. So as we're looking toward the future to expand, we're looking county by county. And I've skipped over the slide, I'm sorry. And we're still focused on community-based by bringing the treatment and the testing right to the doorstep or right to the community rather than relying on the healthcare facilities. So I think I am done. Thank you.
Thank you both so much for your inspirational work and terrific presentation. And just wanted to open up the floor for questions to the audience and then folks that are attending virtually as well. I can certainly get the ball rolling. So you mentioned some of the keys to your success with your program in terms of your successful partnering. What have been some of the barriers over the years that you've had to overcome?
I'm not sure if this is on. Yes. So I think the two major barriers that I spoke about already have been getting, you know, basically how now that we have a woman who tests HPV positive, how can we make sure that she gets the treatment that she needs? And that falls under the umbrella of changing health behavior. So looking at how we educate women in the community, looking at how we educate the healthcare providers and the community health workers who engage in our program. And it has been different for every community that we've worked in. Yeah.
And so, so given that it's been so different in every community, how do you adapt to the contexts where you're working? I mean, you're working all over the world, different continents. What has been your approach to that?
One thing for sure is you can only make a first impression once. So you try to figure out very gently and gracefully what the needs are of the community. Pretty much.
Absolutely. That's probably something that we can all apply to whatever field of research that we're conducting. So I see we have a question.
Hello? Okay, sorry about that. So I guess my question is, and I'm sorry if I missed this, but so you go out and you do all this extensive kind of one-stop shop, if you will, and yet there's still that 30% of people, right, of the women that you're unable to capture, and then also some of those women who might be hesitant to get treatment right then and there, and so you kind of miss out on them. So my question is, have you gone back to the same place, especially because social factors, right? Women that did get the treatment, they're talking to maybe the women that were hesitant. And so maybe they would be more inclined to get that extra treatment, or those that you missed, would be inclined to get the testing the second time around.
Absolutely. When we go back to treat the women, those women that don't want to get the treatment will go back to their little tiny neighborhoods, tell them that the treatment wasn't such a big deal. And then we come back again and we come back again and we come back again. So we're capturing more and more people each time we come back. But our overall recidivism rate is really pretty good, pretty low.
Yeah. So the way that we set up this program in Kisumu County, the 3 sub-counties that I showed were the regions that we targeted. And we spent about 3 to 4 months in each of those sub-counties. And to your question, we are now planning, because there was a number of women who didn't take the opportunity when they had the opportunity. But we have a theory that they might take it now, right? Because exactly what you said, sometimes it just takes time to change your mind or to gather more information. So we are planning in 2024 to go back and target those same sub-counties again, to try to capture those women who did not uptake the testing the first time around.
Dr. Ashe?
Phenomenal work, Dr. Patricia and Rebecca. Such, passion is very much needed to address this burden that, as you said, it's eradicable. So given the high penetration of HPV virus in the population, any opportunity for HPV vaccination among the age-eligible women, as well as their age-eligible children?
Sure. So I think one of the things that has made us very impactful as an organization is that we have a very specific focus, and our focus is on secondary prevention, which is early detection and early treatment. We do work closely, again, with the local and national government and other stakeholders. So when we train the community health volunteers, we use that opportunity to give them training and knowledge on the vaccine, because they're going house to house and giving information to the mothers of the daughters who should be vaccinated. But we ourselves have not yet come into the realm of, trying to implement the vaccine. And I also want to remind you that we have a budget of $1 million US as our operating budget. And that is just not an area where we have been able to go at this point in time.
And in Kenya specifically, children are supposed to be vaccinated at age 13. And I'm very skeptical if that's amounting to any more than 5 to 10% of the kids. Just my opinion.
But it's very admirable to take a very strategic approach with regards to your focus, because unfortunately the resources aren't endless, right? So you have to focus. So although it does seem like there would be some opportunity to be able to partner with other organizations that could perhaps add that element to your program. Is the goal of your program ultimately to be incorporated into various ministries of health? You mentioned that it has been in some places, or what are your thoughts with regards to broader implementation?
I would personally like to have all the clinics taken over by the ministries of health, except for our mobile clinic, which is way too precious, way too expensive, way too finicky. It has to be really tended to with kid gloves. I don't want to see that being taken over, but eventually that too should be taken over.
Any other questions? Any questions online?
I'm just going to cry. I mean, this is amazing what you're doing. It's incredible. Have you seen any, I know the numbers are small now, but do you see any survival rate increases? And, is this really helping people that have HPV and cervical cancer get cured, or what's the ultimate outcome?
We better.
Yeah.
But it's really difficult for us to with our budget to have a real grasp on that. You know, a year after somebody tests positive for HPV and we treat them, we're trying right now to see them again and see if our treatment was effective. But have we done any 5 and 10-year follow-up? No, it's too soon.
Too soon.
It's too soon.
And is there any way you can get the numbers from the government to increase your statistical? No.
Yeah, there is. So
There
that's
is.
an
Oh,
area
that's
that
good.
we want to work on. And Kenya specifically, I think the government is also working to get those numbers, but we do rely on when we work with a new county, we rely on their data for incidence and mortality. And we also have, just anecdotally, cases of women. There was a picture of a woman that I shared earlier who is a survivor. She had, I can't remember what stage of cancer she had, but she did through our client navigation services receive a lot of support, including the NHIF, and also she had to travel nearly 3.5 hours to get her chemo and radiation therapy. And she's alive today. So one of the next, I think, frontiers for us and that we would like to adopt and incorporate into our programs is working with some of those survivors as educators in the community, because they have a very powerful testimony. But as far as measuring our long-term impact, as you're saying, absolutely, that data is so important. And we do track all of our data. And we do track our data we put our data into the Kenyan electronic registry. But I would say that the data that is there from the county is pretty bare. And it has to be a collaboration of different nonprofits and government working together.
That's great.
Yeah, thank you.
Kudos to you all around.
Thank you. Thank you very much. You made my day.
Definitely very inspiring work. You've impacted so many women and community health workers and health system. It's very, very impressive. Any other questions from the audience? Oh, here we go.
I just had one. So are the community health volunteers, are they truly volunteers, or are they
No.
given resources to support them to be able to do this?
We pay them a stipend.
Okay. Yeah, because I'm thinking if they need
And
to
that
be
is
away
the
from their
standard
home.
way. That's
yeah.
standard.
Okay.
Other nonprofits also pay community health workers to do work.
And are there childcare options for the women that are coming to the mobile sites as well?
Oh yeah, when they bring their kids.
Mhm.
Well, when we all entertain their kids when they're there, and when they're getting their treatment, the other mothers entertain their kids.
Yeah, but I also want to add that most of what we're focusing on now is bringing the test kit to the woman's home,
Mhm.
and then only inviting those women who test HPV positive.
Mhm.
And when they come to the mobile clinics, they don't spend more than 30 minutes there. So a lot of the women have given feedback that they really appreciate, because women are working during the day and they're taking care of their children. But as far as childcare options, they're welcome to bring their children to the mobile clinics. You can see it's a pretty casual environment. And it's a very community oriented feel where women hold other women's babies, for example.
We just got back about 2.5-3 weeks ago from a project in Kenya, where our team does the vast majority of work. And we're there to support them and cheer them on.
Yeah, it's wonderful. Thank you.
Well, thank you both again so much. It's been an exciting presentation. I think everyone's inspired and we really appreciate you attending. Thank you.